the debate on NICE appraisal processes for treatments for rare diseases. Liz Twist to move.
Thank you, Madam Deputy Speaker. I beg to move the motion on the order paper that this House believes that the NICE appraisal processes do not properly address the medical treatment needs of people with rare diseases such as muscular dystrophy, phenylketonuria and cystic fibrosis, and calls on NICE to urgently review the appraisal process. And I would like to start by thanking my honourable friend, the member for North Tyneside, who is chair of the All-Party Parliamentary Group for Muscular Dystrophy, and the honourable member for Strangford, chair of the APPG for Cystic Fibrosis, for their help in securing this debate. Madam Deputy Speaker, my constituent, Archie McGovern, is 12 years old. He's bright and lively and full of beans now, but it hasn't always been that way because Archie has PKU, phenylketonuria. Putting it simply, PKU is a genetic condition which means that Archie and others are unable to handle phenylalanine, and which is found in protein. So no meat, no fish, no dairy products and a whole range of other things which you wouldn't think had protein in them. The list is endless. And on top of that, a protein substitute drink, if you can call it that, as it's very unpleasant, to keep the balance right. And PKU is not, at present anyway, curable, and a hugely restrictive diet is the only way of controlling the condition throughout childhood and adult life. The condition is picked up by the pinprick test at birth. For those who are identified as having PKU, it's the start of a difficult lifetime of dietary control, and for children especially, it's most difficult, but also most important, as failure to control the condition can lead to serious neurological problems. That's how it was for Archie until quite recently. But there is a treatment which can help control PKU. It's called Kuvan, and although it was licensed 10 years ago and is widely available in many other countries in Europe and further afield, it isn't available to patients here in a moment. Not everyone with PKU responds to Kuvan, but it's believed that over 20% will respond well and will see a significant improvement in their life.
Well, lady for giving way. She makes a very important point about Kuvan and PKU. As you'll be aware, I took part with other members in a MP's challenge around the PKU diet last year, so I'm very well aware of the restricted diet which was required for those who are suffering PKU, with the honourable member for Dudley North in particular. And the point about Kuvan, I think, to stress, is that the way that NICE evaluates it does not take into account the social costs associated with the alternative treatment, which is a highly restrictive diet, which has impacts on families and on wider society. And I think NICE does need to take that into account.
I thank the honourable gentleman, and yes, like him, I took part in the PKU Diet for a Day challenge, and it was indeed very restrictive, even knowing that it's only for one day. So Archie, as I was saying, is one of those who responds well to Kuvan. And last year, his parents took the really difficult decision that they would pay to buy the drug for him. It took a great deal of soul-searching on their behalf to do that, and it cost them dear, £25,000 a year, and Archie is just on half a dose at present. And they know that for many people with PKU, or for parents with more than one child with PKU, it's simply not possible to self-fund, and they're acutely unconscious of the unfairness of that. The difference Kuvan has made to Archie is real and significant. Increased concentration and energy, meaning he can make the best of his education, no recurring mouth ulcers, which are a real problem, and a chance to substantially increase the number of exchanges he can have and eat a more normal diet. For Archie, it's made a real difference. It was Archie's case and those of others in very many constituencies which led us to form the All-Party Parliamentary Group for PKU and look at how Kuvan could be made available to those who would benefit from it. Nearly 10 years after Kuvan was approved, there did not seem to have been an appraisal of this treatment, nor was it available, nor is it still available in England on the NHS. Since we set up the group, there has been a move for Kuvan to be appraised by NICE, and there have been discussions with NHS England about a managed access agreement. But we were disappointed to learn just before Christmas that no agreement had been reached on the managed access agreement, and that the NICE appraisal was to be via the single technology appraisal route and not the highly specialised technologies programme. I understand that following a legal challenge, the Department for Health is again considering the appropriate appraisal route, and the APPG has certainly made representations on that point. It's too easy when talking about the NICE appraisal systems to get lost in the technical details, the qualies and everything else, which mean nothing to people on the street, when what really concerns people is whether or not they have a fair chance to be able to have the drugs they need fairly assessed and made available to them on the NHS. I will.
I thank my honourable friend for giving way and for securing this debate. One of my constituents suffers from Batten disease and is receiving, I'll word this carefully, Serliponase alpha on compassionate grounds. However, NICE recently ruled not to recommend the treatment due in part to cost. Does my honourable friend share my view that allowing patients onto clinical trials where there's not the funding to deliver the treatment places them and their families in an incredibly difficult and uncertain position regarding their future?
I thank the honourable member. Yes, I most certainly do agree with that, and we see that happen too often. What we need is a correct system which will properly value the drug.
Will my honourable friend give way before she moves on? I thank her. I mean, I have certainly found that NICE sometimes say that the actual pool of people isn't big enough to actually evaluate. But there is a clue in the title. These are rare, and I don't think they can carry on doing this, particularly in cases where it's clear that that drug does have a really positive effect.
I most certainly do agree with my honourable friend's comments, and indeed that's the burden of my presentation, my speech in a moment. So, as I was saying, I'm not going to get into the detail of the process and the fine detail. It seemed to us in the APPG that there are so many conditions which are facing the same problems as my honourable friends have said. Our friends in the All-Party Parliamentary Group for Muscular Dystrophy and that for cystic fibrosis are two which come to mind. But there are many other rare diseases, as we've heard, which don't have all-party parliamentary groups, who face exactly the same difficulties. And since this debate was announced, some other organisations have contacted me to ask me to make sure we don't forget their concerns too. We've found that there are a number of aspects of the NICE appraisal system which are problematic in assessing Kuvan and many other rare drugs. So these are, very briefly, the fact that they are the existence of just two appraisal routes for treatments to be assessed by NICE results in the likelihood of two or more treatments being stuck in the middle by not meeting the restrictive criteria of the highly specialised technology route, and therefore being assessed under a single technology appraisal route. Some of them are rare, but not rare enough. As we've heard, the majority of treatments for rare diseases are likely to be assessed within the single technology appraisal, which is designed for non-rare treatments. This impacts on both the cost thresholds and the approach to evidence, which are all designed for more common diseases. Lifelong chronic conditions. NICE's approach values the lifelong cost of treatments. It looks for near-future benefits as well. This means it's difficult for chronic diseases like PKU and treatments which produce lifetime and indeed life-enhancing effects to get access to new treatments. NICE cost appraisals assume patents don't expire. NICE will assume the existing price of the drug will stay the same. This is illogical, particularly when, as with older drugs like Kuvan, the drug will soon go off patent. This affects the benefits assessment. And non-health costs. NICE performs its calculations based on costs paid and saved by the NHS. This ignores the wider cost to society and individuals caused by diseases like PKU. Madam Deputy Speaker, I don't seek to criticise NICE staff. They work within a system that we have given them, but it's clear from the many questions to ministers, debates in this chamber and in Westminster Hall, the creation of all-party parliamentary groups and correspondence with ministers about individual cases, that there is a very real issue here which must be addressed, and that is why we are asking in this motion for NICE to review their processes to reflect the current issues which we face. Many drug companies have been in touch with me since this debate was granted to send me briefings. They've been keen to explain their side of the argument and to point out what they see as the problems in the NICE appraisal process for their drugs. And there is some overlap in in patient concerns as well. But, Madam Deputy Speaker, I am here today to speak on behalf of the community of people with rare diseases, not on behalf of the drug companies. And let me be clear, the fact that this debate is about nice appraisal processes does not excuse the pharmaceutical companies of their responsibilities. There is a balance to be struck between their need to recover the cost of development of drugs and make a reasonable profit, and a huge responsibility on them to make their drugs affordable for our NHS. In this debate, I've focused on PKU and Kuvan, and with another drug treatment for PKU, Pegvalase, on the horizon, there's a real worry that even with a drug which may produce really life-changing results for a wider group of patients, those with PKU will again be left without the treatment which they need, even when it exists. There are treatments for other rare diseases too, Spinraza for spinal muscular atrophy and Orkambi for cystic fibrosis, which are not only life-improving but life-extending. Madam Deputy Speaker, this is quite simple. There are drugs available that can drastically improve the lives of those affected by rare diseases. So when I hear that NICE's appraisal process is an obstacle to improving lives, I feel really angry. We are reducing the lives of these children and adults to a cost-effectiveness analysis. So we need to find a way forward to amend this appraisal system so that we don't let people fall through the cracks and we don't let people fall behind. The drug companies must also do their bit to ensure that their drugs are affordable to the NHS, especially when early access via a managed access agreement is being discussed. That's why today we are calling on NICE to review its appraisal processes and make the necessary changes to stop people falling through the cracks and make available these drugs which can make such a difference to patients. People like Archie McGovern, my constituent, whose mum Barbara set me along this path as a new MP. Madam Deputy Speaker, I beg to move the motion.
The question is, as on the order paper, there is obviously some pressure on time, so we will start with an 8-minute time limit.
Madam Deputy Speaker, I'm delighted to support this motion in the names of the honourable ladies for Blaydon and North Tyneside. This is a life-changing issue for thousands of our fellow citizens who simply don't have time on their side. A number of my constituents, including those who are parents of my young constituents battling with cystic fibrosis, have brought to my attention the weaknesses in the current NICE appraisal model, and I'm looking forward to reinforcing the honourable lady's arguments with some details of my own that have been brought to my attention. The appraisal model has led to this horrendous block on life-changing cystic fibrosis drugs being made available to them. Vertex's 3 approved medicines and investigational triple regimen may be able to treat the underlying cause of cystic fibrosis for up to 90% of patients. Currently, there is no cure for cystic fibrosis, and half of people with the disease will die before they are 31. Madam Deputy Speaker, I recommend that my honourable friend the Minister instructs NICE to review their current single technology appraisal used to appraise inherited rare diseases in order to come to a solution that can best work for all parties. The current model, which specifically affects Vertex drugs such as Orkambi, is fundamentally flawed, and it is not only directly affecting the lives of my young constituents suffering with cystic fibrosis that have been brought to my personal attention, but of course also those with spinal muscular atrophy, Batten's disease and PKU, to name but a few. NICE's single technology appraisal has been used for the last 20 years, and whilst it served as an important new way to assess the cost-effectiveness of new treatments, it fails to keep pace with advances in science. And any model should not be biased towards favouring specific medicines, but there remains an unwillingness to accept that new precision medicines, which treat the underlying cause of disease and have the potential to extend life, are fundamentally different to the medicines that existed when NICE's processes were first developed. This idea of working on an innovative new model for appraising rare diseases is also supported by the Genetic Alliance. And when performing a single technology appraisal, NICE applies the same methodology and cost-effectiveness criteria regardless of whether it is appraising a single-use medicine for an acute condition or a lifetime medicine for an inherited, progressive, incurable, life-limiting disease. And the current evaluation process turns on the incremental cost-efficiency ratio, the ICER, measured in quality-adjusted life years. With acute conditions resulting from shorter-term treatment, the ICER is moderated even if the drug is very costly. Conversely, with chronic and lifelong conditions, the drug must be taken every day for life, and the cost of lifelong treatment prevents downward moderation of the ICER. And this means that when evaluating medicines that extend life, those that treat conditions where patients would die within a short time period are favoured over those that extend life far into the future. This unfairness is doubly compounded by the fact that when computing the number of quality-adjusted life years attributable to a treatment, NICE usually applies a discount rate of 3.5% per annum, based on the Treasury Green Book, on both the costs and health effects of the medicine by reference to how far into the future those life years will be added to the patient's life. In essence, the longer a patient lives, the more expensive they are to the system, and the higher the cost per quality-adjusted life year. By way of an example, if a treatment were projected to extend a 6-year-old cystic fibrosis patient's life expectancy from 47 to 57 years, the present value of those additional 10 years will be less than 2 once they're discounted. By comparison, an oncological orphan medicinal product may add 5 life years, starting immediately to a patient's life expectancy, so discounting would reduce those 5 years to 4.66 for the purposes of calculating quality-adjusted life years. This approach cruelly fails to account for the fact that every year of additional survival, regardless of whether it's gained in the short or long term, will be valued equally in the mind of a cystic fibrosis patient and their family. And to add injury, NICE currently does not take into account that when medicines lose their market exclusivity after patent expiry, their costs to the NHS fall dramatically, typically 80 to 90%. And it's unrealistic to assume that a medicine would remain at its currently listed price over the entire model horizon, particularly when this can be upwards of 40 years. There is no reason why NICE could not model the effect of a post-patent expiry price reduction by reference to available evidence from the pharmaceutical market. Yet another example of where NICE discriminates against treatments for chronic and incurable conditions in favour of those with acute conditions. Finally, while NICE recognises that medicines for very rare diseases, ultra-orphan medicines, need a higher threshold and more discretion in the way they are appraised, it does not allow cystic fibrosis medicines to be judged against this threshold. And this is because, although cystic fibrosis is a rare disease globally, its prevalence in England is such that NICE insists it's appraised via the conventional approach. Vertex is not the only manufacturer of precision medicines for rare diseases to experience challenges with NICE. Both the Bioindustry Association and the Association of the British Pharmaceutical Industry have, on behalf of their members, repeatedly highlighted the need for NICE to be reformed, to take a broad view of the value of new treatments and innovations to the health service, and incorporate a wider range of factors and flexibilities beyond the standard cost per quality adjusted life year gain. It's right that we ensure that NICE processes are modern and up to date with the evolution of precision medicines. And, Madam Deputy Speaker, my constituent, Sharon Cranfield, is frankly a bit disappointed with the letter sent by the Chairman of the Health Select Committee to the Minister outlining the conclusions of the committee's public hearing on the 8th of March. And she says that points that I have raised, particularly on her behalf, don't appear to have been considered, and the findings of the committee seem to lie with continuing to defend the NICE model that's been used for the last 20 years, and an unwillingness to accept that they need to be re-evaluated to reflect the current and near-term developments in precision medicines. Now, I understand that committee may have advisers who might have been associated with the setting up of NICE. I think we need ministers and NICE and everyone engaged in this to look forward to a model that is actually going to work into the future of the people we represent. NICE must re-evaluate the way they value rare disease medicines, and I sincerely hope that following today's debate, NICE do more to achieve alignment on value, evidence and price for the sake of patients, and once and for all address the limitations of the current NICE SDA process for diseases like cystic fibrosis, but also for the benefit of all those other patients who already suffer enough, having been diagnosed with a rare disease.
Mary Glindon.
Thank you, Madam Deputy Speaker, and it's an honour to follow for the member for Reigate, and I would like to thank the Backbench Committee, the Backbench Business Committee, for agreeing to this debate, and to congratulate my honourable friend, the member for Blaydon, and, as she said, fellow member of the All-Party Group for Muscular Dystrophy, because she's made a very lucid case and a compelling case for a review of the NICE appraisal process. Madam Deputy Speaker, I've had the honour of chairing the All-Party Group on Muscular Dystrophy for several years now, and the group works closely with our Secretariat, Muscular Dystrophy UK, patients and carers on a number of issues that affect the lives of those with muscular dystrophy and other neuromuscular conditions. And perhaps one of the most important issues we consider is that of patients being able to access treatment for their conditions. For over a year now, looking at the access to the drug Spinraza, manufactured by the company Biogen, this has focused the APPG's concerns and frustrations with the NICE appraisal process. Spinraza is the first and only treatment for patients with spinal muscular atrophy, SMA, a rare inherited neuromuscular condition that leads to the gradual loss of the ability to walk, move, breathe and swallow. It currently affects about 2,000 adults and children in the UK. There are several types of SMA, with type 1 being the most severe and usually resulting in the death of infants before they reach their second birthday. However, clinical trials of Spinraza have resulted in amazing results for many of the patients who've tried it. It's been so positive for children with type 1 that over 2 years ago, Biogen opened its global expanded access programme to provide the drug free for type 1 patients. Currently, Spinraza is available across 24 European countries and in the US, but for patients in this country, access to the drug is being held up by lengthy delays to the NICE appraisal process.
Honourable friend, give way on that point.
I will give way.
I thank my honourable friend for giving way on that point. Would she not agree with me that we should agree with the honourable member for Reigate that we really should really have a new model, but more importantly, something's got to be done about the costs of drugs. We can't go on with the escalation of these costs, because the honourable member for Reigate said that affects many families in different ways. Would you not agree with me about that?
Well, that's exactly true, and I think it's going to be highlighted again and again in this debate. It's made all the more frustrating, actually, because the Scottish Medicine Consortium approved Spinraza for children with SMA type 1 last May, and they've got now a new ultra-orphan pathway, which is and they've speedily reassessed Spinraza, and as a result, children and adults with SMA types 2 and 3 can access the drug from next month. In England, the Spinraza appraisal has already been going on for 14 months. In January last year, NICE announced the pathway for the drug would sadly be the single technology appraisal, or STA, used for common diseases rather than the highly specialised technology, the HST, which has been spoken about and used for rare conditions. However, on the 14th of August, all hopes were shattered when NICE announced it didn't recommend funding by the NHS, as clinical effectiveness of the drug was not proven and the price was too high. NICE launched a consultation and held a committee meeting in October to review all responses. There was still no progress for the patients. Then, following a previous announcement, on the 1st of November, Biogen closed the EAP for type 1 to all new infants. So although 80 children remain on the programme, any child born after that date with type 1 has no access to this life-saving drug. The process drags on, and NICE has just had its third committee meeting earlier this month, but as yet no information has been published. Biogen itself maintains that the STA process is not appropriate for rare disease medicines because the smaller patient populations and rare diseases make it inappropriate to expect treatments to achieve the same cost-effective thresholds as for medicines in disease areas with much larger patient populations. They have pointed out that it's very difficult to measure the quality of life in a young paediatric population. However, this is a major determining factor in the STA process and so is a stumbling block in approving Spinraza. The company still hope that a managed access agreement can be reached with NICE and NHS England. The truth is that NICE's emphasis on cost effectiveness stands in contrast to the focus on more flexibility and data gathering for future review, which has allowed Spinraza to be approved in Scotland and across Europe. A recent report by Pharma, Access to Orphan Medicines, highlighted that 75% of rare disease medicines recommended by NICE through STA between 2013 and 2017 is due largely to rare cancer drugs that are covered by the Cancer Drug Fund. And of the only six non-cancer orphan drugs reviewed by NICE through STA, none have reached a recommendation in line with full marketing authorisation. The report does make 5 recommendations for the NICE STA methods review, including changes to the evidence requirements for orphan medicines, drawing from the HST methodology to consider introducing a sliding incremental cost-effectiveness ratio up to £100,000, to consider adapting the evidence review group for orphan medicines, embed formal opportunities for negotiation between companies and the NHS England, and to consider interim recommendations in line with the Cancer Drugs Fund and the new Scottish Ultra-Orphan Pathway. Matt pointed out that these adaptations will help to level the playing field so that patients, clinicians and companies can be sure that all treatments for rare diseases will be considered under a fair appraisal and that access will not be held back as a result of treatments being referred for inappropriate appraisal. Recommendations that I hope will be given due consideration by NICE, NHS England and the Department. Meanwhile, for those awaiting a decision on Spinraza, the anxiety continues. Families like that of my 7-year-old constituent, Sam McKee, who is type 2 SMA. Sam loves playing wheelchair football, has played since he was 3, and he's now part of the Newcastle Magpies wheelchair championship team. He's as good as many of the adults, and he's so good that in November, Newcastle United Foundation named him as their Disability Player of the Year. Sam's dad, Gary, wrote to me, and his words reflect the views of everyone affected by SMA. And I quote, "Children are facing agonising and uncertain waits for approval whilst their condition deteriorates. Gaining early access to this drug could see Sam get stronger and gain new abilities. The SMA community would love to be able to access this drug to give our babies and children a chance they surely deserve. This drug is available now, and tiny procedures are stopping our children from accessing it. This is wrong. Please help us." Will the Minister hear Gary's words? Will he take action to ensure delays don't happen in future? And will he work with Muscular Dystrophy and other charities towards help making NICE take on board MAP's recommendations to help create a new, fairer system like that in Scotland, which will deliver for patients like Sam and, as Gary Mackey says, give them the chance they deserve?
Eleanor Smith.
Thank you, Deputy Speaker. And it's an honour to follow my member of North Tyneside, and it's an honour as well, and thank you for the honourable member for actually bringing this debate to from Blaydon. I first heard of the drug Spinraza last year when Katie Prescott contacted me about her 10-year-old daughter Heidi. She wrote, "I have a daughter Heidi with a rare muscular wasting disease called spinal muscular atrophy, SMA. SMA ranges from a very severe type 1, through to type 4. Heidi has type 3, and she's fast losing the ability to walk. She's 10 years old, and it's a devastating prospect for her. For the most severe cases of SMA, life expectancy is only 2 years without the access of this drug. There is a treatment available for SMA, and it's called Spinraza. It's the one and only available treatment for SMA. 22 other countries, including Scotland, have approved it. However, NICE are recommending that the NHS England do not fund Spinraza for any type of SMA, meaning thousands of people in the UK with SMA are left without a treatment. It's practically a death sentence for babies diagnosed with type 1.
Yes.
And it means type 2 and 3 children are destined for a life of deterioration. The issue is that NHS England and Biogen cannot agree on the costs.
Yep.
We need the government and the NHS England and Biogen to sit down and negotiate an agreement which has the SMA community at its heart. In January 2019, I wrote to the Health Secretary, and he replied, NICE is an independent body and it would be inappropriate for me to comment on its guidance. When I wrote to NICE for the clarification, it said, I fully accept that we, the company, and NHS England have a responsibility to bring this matter to a conclusion quickly. We are working hard to do this through discussions with the company, and I'm hopeful of reaching a positive outcome. I also asked the PM the question, why is this treatment not available to my constituent Heidi and other children in England with this disease? She answered that the next meeting between the parties would take place in March. Since then, NICE and NHS England and Biogen have met on March the 6th in Manchester. And now we await their next judgment. This is after 14 months of appraisals already, with months between the negotiation process.
Yep.
I want to ask again today, what is it about this country that makes it so different to Scotland and the 22 other countries in Europe that have approved this drug? What's the difference? What have they done to be able to do that? How have they negotiated this? When a child is born with a condition like SMA, there is hope in every parent's heart that a cure will be found, a new drug will be developed to treat. Here we have an example of this, but it's denied to the children suffering with SMA. We must find a mechanism to resolve these problems. I understand there are structural issues within NICE, which means that the treatments of these conditions, like SMA, end up being assessed in the same way as the more common conditions, therefore making it extremely difficult for treatments to be assessed at being cost-effective. In the meantime, Heidi's health continues to deteriorate. When I met her recently in my office, I was deeply impressed with her bravery and optimism. But as her mother said to me, it's very frustrating that still no decision has been made. Heidi cannot walk unaided anymore, and even then can only take a few steps. To know that there's something that can help her, but she can't access it, is very difficult, and Heidi finds that hard to deal with too. Up and down the countries, families like Heidi are fighting for this treatment. Surely NHS England and NICE and the company have a duty of care and a moral obligation to give treatment to patients like Heidi when it's available. Behind the statistics of issues like this, we must remember that there are human beings with caring families who are suffering because of how medicine is being denied in this country.
Corinne McCarthy.
Thank you, Mr Deputy Speaker, and I will be brief because I have spoken on this issue many times before, and I talked specifically about cystic fibrosis. But before I get on to that, I did want to congratulate my honourable friend, the member for Blaydon, on her speech about PKU. I actually popped into the drop-in event when it was held a few months ago, purely by accident. I was doing one of those classic things that MPs do where they're asked to go here, there and everywhere, and usually photographed holding up signs or wearing silly hats or whatever. And I knew nothing about PKU, but there was an 11-year-old boy there, and talking to him about his diet, and I'm somebody that chooses to have a pretty restrictive diet in that I don't eat things like meat, dairy and fish, but obviously I look for protein alternatives, and just the the sheer, difficulty of him functioning and not being able to enjoy the normal life of an 11-year-old boy, my heart really went out to him, and I don't need to add any more because it was such an excellent speech from the member for Blaydon. We've also had an excellent speech about Spinraza and the difficulties obtaining the drug there. I've got constituents that have been in touch with me. I don't claim to be an expert in the way that some of the other members are, but I would very much support efforts to get approval for that drug in that it would make a huge difference to their lives. But as I said, I'm here to talk about cystic fibrosis. I have a personal interest in that. I have a 14-year-old niece, Maisie, who I think must be the most mentioned niece in Parliament because she just get name-checked quite a lot. But before I talk about Maisie, I was reading the testimony given by Ollie Rayner to the Health Select Committee recently. He's somebody who's living with cystic fibrosis. He's, I think, just turned 40 now. He had a lung transplant 18 months ago. So actually he is at the healthier end of the spectrum. He says that he was actually quite lucky till he got into his 30s when his health started deteriorating. Many cystic fibrosis patients aren't as lucky. I have a constituent, Lee Partridge, who lost both his daughters I think they were both in their late teens, 8 months apart from each other, and that is quite a common pattern that people start to deteriorate when they get into their teens. And as I said, I have a 14-year-old niece who luckily is very much at the healthy end of the spectrum. But that does not, influence my judgment in terms of wanting to make the case for Orkambi to be there, not just for her when it's needed, but for everybody else with this condition. And, I can't pretend I've been sitting here trying to get my head around all the discussion of quality-adjusted life years and how the calculations are made, and whether NHS England is doing the right thing, and whether NICE are using the right sort of calculations compared to other countries. I was looking at... They say that they factor in societal benefits, but it wasn't very clear to me how they actually do that. And the point has already been made by the Honourable Member for Reigate, who I thought made an excellent speech about the cost to society as a whole, the hospital treatments, if you're having to go into hospital for several times a year, the cost of the care in that hospital, but also the lost work time, the fact that family members have to care for them, transportation even to hospital, things like that if they live in a rural area. So many of those factors, and I couldn't quite see, although NICE says that it takes those things into account, it seems to me that what is actually done is a very... there was a phrase that, was it somebody used about Hugh Dalton, I think, that they called him a desiccated calculating machine. Was it about Dalton? Or was it about Attlee? I'm not sure anyway, but it seems like that, this desiccated calculations, that seems to me very much what the system is based on. And it may be incredibly naive of me to say, can't we just think about the impact on people's lives and the hell that they are absolutely going through. And it is an incredibly difficult thing for teenagers to come to terms with as they discover that they have life-limiting conditions. There's also an issue about mental health support for people in such conditions and the counselling that's available. But I just have a couple of questions that I want to put. I mean, it was striking that everyone who gave evidence to the Health Select Committee said that the drugs work. There's no question that this would actually be of benefit to people. My concern is it looks as if Kalydeco, the first drug that only helps 5% of patients, was funded in part because there weren't many people that were actually going to benefit for it, so therefore the costs were lower. You now have Orkambi, and there's soon to be a successor to that would benefit about 40% of patients. But we're looking in future at triple therapies that would cover about 90% of the cystic fibrosis community. And there just seems to me a complete, yes, of course, if 90% of people can benefit from it, the cost is going to go up overall. But it seems to me that decisions should not be made on that sort of basis, that you can fund one thing because actually not many people are going to benefit from that. And I'm concerned that Vertex and other companies will be deterred from exploring further therapies and further treatment if they can't get a commercial deal going already. I would note, however, that in the letter that the Health Select Committee wrote to Vertex shortly after the committee met, they did say that they The line that jumped out at me, Vertex appears to have decided on the pricing of its therapies on the basis of the return it wants to make, rather than the value which they bring, rather than the value that they bring. And NHS England is right to continue to take the wider patient population for whom it is responsible into account. So basically this is just a plea to the Minister. I know he's responded to these debates before, but can we have an update on where the conversations have got with Vertex, including the meeting the Secretary of State had, and can we, there are so many cystic fibrosis patients waiting to hear the outcome. There's a petition that last time I looked was up to about 80,000 signatures. Can we try and get some answers soon?
Lynn Brown.
Many grateful, Mr Deputy Speaker. I'm sure members today won't be surprised to hear I want again to talk about baby Mariam, my constituent who is now 7 months old, who has spinal muscular atrophy type 1. Without treatment, Mariam will only have a few more months to live. She's waiting for NICE to announce a decision to allow access to Spinraza, the drug that she and other babies with that condition so desperately need. I want to start by thanking my honourable friend, the member for Blaydon, for securing this important debate, the Daily Mirror, especially Pippa Creer, for telling the stories of SMA families, the campaigning newspaper, the Newham Recorder, for their continued coverage and encouragement, and the amazing members of the local community in West Ham for their support, especially Councillor Maz Patel, who's been absolutely brilliant, as has Kevin White and many others who have taken the plight of this little baby to their hearts. But most of all, I'd like to pay tribute to Shaquille, Mariam's father, and all of Mariam's family, who have steadfastly campaigned, knowing that when we finally get access to Spinraza in England, it could so easily be too late for Mariam. SMA1, as we know, is an awful disease. It's a progressive muscle wasting condition, and for a baby it causes difficulties with breathing, swallowing and gaining weight. Babies with SMA1 may not even be able to cry out loud. Spinraza is an effective treatment for SMA. With this treatment, babies, children are living longer. They're even crawling and walking. And I'm told that by last August, when NICE first met to consider funding Spinraza on the NHS, none of the babies who've been treated with it in the UK had died as a direct result of their SMA. The drug was so effective that the trials stopped early. Nevertheless, NICE has refused to approve Spinraza at that August meeting, or at the second meeting in October, or in November. And in November, the expanded access programme, which allowed treatment with Spinraza while negotiations were ongoing, was closed. Biogen, the drug company who developed Spinraza, closed it. So when Mariam was diagnosed in December last year, she had no access to this drug, even if it could have been afforded privately, even if in my community in West Ham had fundraised for it, and I can tell you there has been an awful lot of people wanting to do just that. But even if they had done that, offered to do it, managed to do it, she couldn't get that drug. But we're not talking about huge numbers, Mr Deputy Speaker. We're talking about less than 100 babies a year. And treating this condition couldn't surely break our bank. NICE met again 2 weeks ago. We held a vigil whilst they were making their decision. But I'm told it could be 3 or 4 weeks before that decision is done. It's callous. Making families, making Mariam, making the other babies wait this long is callous. The NICE approvals process for Spinraza has now taken 14 months. That's longer than many of the babies with SMA can be expected to live without the treatment. At the same time, agreements have been reached on Spinraza in the United States and in 25 European countries, including Scotland, Germany, Italy, Lithuania and Romania. NICE have failed Mariam and all the other babies with SMA, but others are culpable too. The closure of the access programme no doubt saved Biogen, the drug company, some money, but I'm sure that it was closed to increase pressure on NICE as well. I can't say if that's definitely true, but what I will say is that if it is true, the suffering of tiny babies and the pain and suffering of their families too has been used in the service and pursuit of profit. I now believe that our whole system of for-profit medical research combined with public health care encourages this kind of brinkmanship. It encourages delaying tactics. It encourages the exploitation of sick children and their families. But let's also consider the actions or inaction of government. I'm sure honourable members will recall how in the spring statement the Chancellor talked of a proud, successful, outward-looking nation with no limit to our ambition and no boundaries to what we can achieve, about the single largest cash commitment ever made by a peacetime British government for the NHS. Surely we can afford to help these babies too. Currently, we are the 5th richest country in the world, and yet we're withholding vital medical treatment for babies. Medicine that 25 other European countries, including some much poorer than we are willing to provide. So what does that say about us? What does that say about our values? What kind of a country have we become? I've asked the Prime Minister to act twice. I've asked the Secretary of State for Health to act. So far, I can see nothing's happened. I hope honourable members opposite will forgive me when I say that I thought that the Prime Minister's response to me last week was cold and more concerned to defend an outdated process than to understand and empathise with the desperate plight of Mariam and her family. Remember, 25 European countries already have access to the drug, and we don't, and yet it seems to be nothing to do with the Prime Minister.
Lady for giving way. She's making a very, very powerful and good speech. I have two constituents, Mark and Panna Wilson, who are in a similar situation to her constituents. Their son, Ardi, is only 3 years old and is regressing every day because he also has SMA, a terrible condition. They've told me that without access to new treatments, each and every day is a step not towards an exciting future, but towards a painful and dark place. The Honourable Lady is quite right, and I hope for the benefit of the Minister that we will find a new route to approve Spinraza in this country. The route that's going through is really intended for much more generic medicines. It's not been put through the route for very rare medicines. We either need to put it through that route for the rare medicines or to find and invent a new mechanism so that we can get treatment for these people. As the Honourable Lady pointed out, this is a rich country. We must be able to save these babies and toddlers.
The honourable gentleman is absolutely right. This is a political issue. What we're discussing today is political. I mean, it's about which of our constituents get access to which medicines and when, who our public health care service helps with our public money, and who we allow to die without help. Honourable members on both sides have recently urged the government to use its Crown use licences power in the case of Crombie. These powers can get around medicine patents when pharmaceutical companies are simply refusing to deal honestly with our NHS, and this is an option. There are always options for government if they wish to use it, but the government seems content with voicing frustration. They don't do anything. They won't even threaten to do anything that might help. If the Patents Act isn't working, as ministers have said, then we need to do something to replace it. Mariam's family and others want action now. They need Spinrazas now. When will they get it?
Even twit.
Thank you, Mr Deputy Speaker, and it's a pleasure to follow my honourable friend from West Ham, who I think made her case with great power and passion. Can I also congratulate my honourable friends from Blaydon and North Tyneside for securing what is an important and timely debate today. Until recently, I had the pleasure of chairing the all-party parliamentary group on rare genetic and undiagnosed conditions, which receives secretariat support from the Genetic Alliance UK. The aim of the group is to raise awareness about these conditions here in Parliament and to ensure that patients and families can get access to appropriate care and support. And my honourable friend, the member for Hornsey and Wood Green, has taken over as chair of the group, and unfortunately she had prior commitments today, but otherwise would have been here to take part in this debate. In my constituency in Liverpool, I have the fantastic Alder Hey Children's Hospital, and Alder Hey works in close partnership with the University of Liverpool and the charitable sector to provide more research opportunities for children with rare diseases and their families. For For example, in the rare neuromuscular diseases, Alderhay has worked with patient advocate groups and national charities to increase capacity and resources to offer access to clinical trials of new disease-modifying agents. Since 2016, Alderhay has opened 19 new clinical trials in Duchenne muscular dystrophy alone, enrolling nearly 100 boys in these very important trials. Providing excellent world-class clinical and research expertise and working in partnership with the voluntary sector has enabled Alderhay to provide more opportunities for children with rare diseases to take part in crucial research studies. In the role as chair of the APPG, it was a privilege to get to know the rare diseases community. And during this time, the issue that was consistently raised with me by patients and their families, clinicians, the pharmaceutical companies, was the challenges that they face attempting to navigate NHS England and NICE's appraisal processes for rare disease treatment. Patient access to new orphan medicines in the UK, as other members have said, lags behind many other European countries, including Germany, France and Spain. The Office of Health Economics found that the UK is both slower at making access decisions and approves far fewer medicines for reimbursement than other European countries. And according to the recent MAP Biopharma report, using data from a 4-year period, almost a quarter of licensed orphan medicines have not been appraised at all by NICE or NHS England. This can prevent rare disease patients from having any opportunity to get access to treatment, and the lack of capacity to appraise orphan medicines is just one of the systemic flaws, and we've heard about others today, with the current system of NICE appraisal. The multiple pathways through which medicines can be appraised create further complications and delays, and it's often unclear why one route is chosen over another, so that very similar orphan medicines can be subject to very different assessment criteria. We also know that patients are often stuck in limbo, waiting for the results of private negotiations about price between companies and the NHS years after the market authorisation of their potential treatment. It's against this background that the all-party parliamentary group asked Genetic Alliance UK to propose a method of making decisions about rare disease medicines that would be more effective, transparent and fair. The project is called Resetting the Model, and it aims to develop a flexible new vision for getting access to rare disease medicines for the UK, and it will be delivered over the coming months. It is absolutely clear that the current NICE appraisal process is simply not fit for purpose, and it is acting to restrict many rare disease patients from having the opportunity to get access to potentially life-changing treatment. Let me, Mr. Deputy Speaker, address a related issue. NICE has been consulting on guidelines for cannabis-based products for medicinal use, and on Tuesday I had the pleasure to meet my constituent, Lauren Abernethy. Lauren is the mother of Nathaniel. Nathaniel is 10 months old, and he has a type of epilepsy that is so rare that when he was diagnosed, his doctors told Lauren, his mum, and his dad, James, that Nathaniel is the only known case with this type of genetic mutation recorded anywhere in the world. For the next 3 months of his life, Nathaniel was in Alderhay Hospital undergoing tests, and for most of that time he was in critical care. Lauren was here on Tuesday as part of the End Our Pain lobby of Parliament. Due to the extremely rare type of epilepsy that Nathaniel has, anti-epileptic drugs don't work, and Nathaniel was granted the use of Epidiolex, a medical cannabis product. He has reacted positively to this treatment, going from being in a state of continuous seizures to now having on a good day as few as 3 to 5 seizures a day. However, despite that progress, he continues to live in great pain, and he jerks and twitches continuously. This is known as myoclonic jerks, having up to 100 of these every day. Access to full extract cannabis oil might offer him the better quality of life that surely Nathaniel deserves. Like so many other children who are suffering from intractable epilepsy, Nathaniel has so far been denied access to this treatment. I welcome the decision last November by the Home Secretary to reschedule certain cannabis-based products for medical use, but the reality for patients like Nathaniel is very different. Only a tiny handful have succeeded in getting a prescription. Patients, some of them, as in Nathaniel's case, very young children, are being blocked from access to medicine, which the evidence shows has at least a possibility of relieving their symptoms. And I urge the Minister, in his response today, to talk about how a policy can be put in place based on evidence that actually enables patients with rare diseases who could benefit from medical cannabis to get access to it. And more broadly, can I echo the comments that have been made on both sides of the chamber and ask the Minister today to set out what he will do to take this crucial set of questions forward, and in particular, will he work with the Genetic Alliance so that we can reset the model working with NICE and NHS England so that patients with rare diseases get the fair access to medicines and treatment that surely they all deserve.
Thank you, Mr Deputy Speaker, and it's a pleasure to be able to make a contribution to this important debate. I also want to thank my honourable friends, the members for Blaydon and North Tyneside, for obtaining this debate, and the Backbench Business Committee for granting it. Now, before I was elected to this House, I worked for over 30 years as a clinical scientist in our NHS. During that time, I did develop a healthy scepticism for politicians advising on medical treatment. I feel is best left to clinicians. However, I did want to take part in this particular debate because I know that issues around the availability of life-saving drugs and treatments for rare diseases are important to many people. And I have been made particularly aware by my constituents about the unavailability of Orkambi to cystic fibrosis sufferers and Kuvan to those affected by phenylketonuria. And I also think this debate is extremely valuable because it is focusing upon the way that the National Institute for Health and Care Excellence, NICE, operates, and questions whether that operation is actually appropriate for those suffering from rare diseases. The definition of a rare disease is generally considered to be one affecting fewer than 5 people in 10,000. However, large numbers of people are affected by rare conditions, with the UK Strategy for Rare Diseases estimating that in the UK alone, more than 3 million people will suffer from a rare disease at some point in their life. However, because relatively small numbers of people are affected by a particular rare disease, there are specific challenges in ensuring speedy diagnosis and access to appropriate services and treatments. And the technology appraisal process used by NICE involves looking at evidence from clinical trials and peer-reviewed research showing how well a medicine or treatment works, including its likely impact on mortality and quality of life. It looks at economic evidence on how much it costs the NHS, and also the views of clinicians, patients and other stakeholders. And as well as looking at the clinical effectiveness of a treatment, single technology appraisals and highly specialised technology evaluations also assess its cost effectiveness. And as many speakers have said before me, this is usually measured in terms of the cost per additional quality-adjusted life year. And this is assessed by looking at how many extra months or years of life of a reasonable quality a person might gain as a result of treatment. And following changes introduced in April 2017, NICE set a maximum additional quality-adjusted life year threshold of £300,000 for highly specialised treatments, under which they will automatically be approved for routine commissioning. And this is 10 times higher than the standard NICE threshold of £30,000 for non-specialised treatments. However, because of the nature of lifelong genetic diseases, the required quality of life improvements are likely to be unobtainable. The charity Genetic Alliance highlights that no ultra-orphan treatments, drugs that are used to treat extremely rare diseases, currently used by the NHS would pass this test. It's clear that an urgent rethink is needed on these policies. These policies are focused almost exclusively on price, to the detriment of patient outcomes. The Genetic Alliance has argued that these policies will halt future access to innovative treatments for rare genetic conditions in England. They also contrast with the stated aim of the UK Strategy for Rare Diseases to ensure that there are appropriate procedures for evaluating the costs and benefits of treatment for patients. The problem with the current NICE appraisal process is that treatments, particularly those designated as orphan medicines, are not eligible for the narrow criteria of the highly specialised technology process, but are not appropriate for the single technology appraisal process either. And the reasons for this could be because the treatment's patient population is marginally higher than the maximum size considered through the highly specialised technology process, whilst the single technology appraisal process is inappropriate for most orphan drugs because of limited trial data. The Accelerated Access Review, which aims to speed up access to innovative drugs, devices and diagnostics for NHS patients, recommends that NICE should undertake a review of its methods and processes to ensure that they are fit for purpose. And I think all in this room would agree that that was long overdue. The Accelerated Access Review warns, and I quote, "It is important that no group of products can fall between the cracks and struggle to find a decision-making process." And we've had some heartfelt speeches today from my honourable friends, which I think have illustrated that some products are falling through the cracks and families and young children are suffering. The views of the Accelerated Access Review are also in line with the views of the NHS 5-year forward view, which includes a recognition of a broad measure of value that goes beyond price alone. Now, I've combed through the NHS long-term plan, the latest NHS plan. I cannot find any reference to this issue, this really important issue, in the current long-term plan, and I'd be grateful if the Minister, when he responds, could point out to me where the issue is referred to in the latest iteration of the NHS plan. NHS England and NICE need to reconsider how they account for rarity in their assessment processes to support the NHS in its mission to provide a comprehensive service available to all at the point of need, including those with rare conditions.
Ian Austin.
Thank you. Thank you, Mr Deputy Speaker. And I want to start by thanking the members for Blaydon North Tyneside and the members on the Backbench Business Committee for arranging this debate today. And I'm here today to speak up for people in Dudley with cystic fibrosis, phenylketonuria, or PKU, as I'll be referring to it, and spinal muscular atrophy this afternoon. Now, Mr Deputy Speaker, I've been campaigning with others to make or can be available for people with cystic fibrosis and other new treatments, because I was contacted by Carly Evans from Dudley, who took part in the clinical trial for Orkambi, and by Samantha Carrier, whose baby daughter Daisy was diagnosed shortly after birth and who now has given up her career and who now devotes her life to campaigning for access for these life-changing drugs. And I want to mention as well, Mr Deputy Speaker, that I've been, whilst listening to this debate today, I've been receiving emails and texts and other messages from people around the country, heroic parents of children with cystic fibrosis who work so hard and campaign tirelessly for the treatment that their children need. And I know that the Minister's met some of these parents before, and I hope today he's going to have some new answers for them, because they'll be, waiting for. They've worked so hard to raise these issues, and these issues really do need to be sorted out. Before the clinical trial Carly Jevons had to take 90 tablets and do 2 hours of physiotherapy a day. She had a lung function of around 44%. She spent 2 weeks in hospital every 3 months. She had to choose between the financial hardship of leaving work or her health being made worse as she struggled on at work. She told me, she said, Orkambi has changed my life. My health has remained stable. I only need 1 or 2 courses of IVs per year instead of the 4 previously. Hospital visits have been massively reduced and unplanned admissions are non-existent. Since having Orkambi, she's been able to go on holiday abroad for the first time with her family. She's got married, she's started a business, she's employing people, she's making a much bigger contribution to the economy. And I think the government need to look at the contribution that people who get these drugs can make to the economy and not just the costs of providing these drugs. This afternoon, I think NHS, England and NICE are meeting Vertex for yet another meeting on whether these cystic fibrosis drugs can be provided. But this comes 3 years after NICE appraised Orkambi. And I really hope that the Minister is going to explain today how situations like this can be, well, how this situation can be resolved and how other situations like this can be avoided in future so that patients can get access to these drugs. I also wanted to speak in the debate today to raise the issue of treatments for people with PKU. Some of the people who have been leading the campaign for this are sitting in the public gallery watching this debate, and again I hope that the Minister is going to have some good news for them today. This is a rare metabolic disease, as we've heard, that leaves people unable to metabolise protein properly. It leads to a toxic build-up of material which can cause irreversible brain damage. The only existing treatment is a strict diet of extremely low protein, meaning almost all normal foods are off limits. The diet's lifelong, sufferers find it stressful and difficult to cope with. I'd never heard about this until a woman in Dudley called Kirsty Thornton got in touch with me, and since then I've met the campaigners, I've taken part in the PKU Diet Challenge. I joined the cross-party parliamentary campaign led by the Honourable Member for Blaydon to ensure that people with PKU get access to the treatments and supplements that they need. And it's heartbreaking, I think, for parents of young kids with PKU, the children who they don't understand why they can't go to their friends' birthday parties in case they eat the wrong foods that will make them tired and sick and ill for the rest of the day or for longer. And I think when you listen to students tell you that how difficult it is when their friends are going on nights out, or they move to university and the people they're sharing a flat with are ordering in pizzas and all the rest of it, or they can't go out on a date because they don't know what they're going to be able to eat or not. I think this must be really, really tough for young people. Yes, of course, yeah.
My friend will probably be aware that the government is looking at a new food strategy, and one of the things under consideration is better food labelling. And I think this just brings home to us, a lot of people think that people who make certain dietary choices do it almost like to be trendy or to, it's just the fashionable thing to be. But there are people whose lives are at stake if they can't get the information that they need on food. And I think both food manufacturers and anyone else involved in the provision of food to people need to be alert to the fact that it's important that people know what they're going to be eating.
This is a really important point. And the campaigners for PKU have explained to me that on some occasions manufacturers have changed the ingredients in food or drinks, which have had a terrible impact because people with PKU have not necessarily known about this. And they've been affected. They've continued drinking or eating things that they've eaten or drunk without any problems in the past, but because the ingredients have changed, it's caused them a big problem. Now, for many people with PKU, taking Kuvan considerably increases the amount of protein that they can safely eat. So we're urging the government, the NHS and BioMarine, who manufacture these supplements, to agree a deal so that people with PKU can enjoy a normal, healthy life. The National Society for PKU, we spoke to them this morning. They told me the whole PKU community are demoralised. They say they're working hard, but they feel that not much progress is being made. So I want to ask the Minister today, what is he going to do to give these people, some of whom are in the public gallery, others of whom are sitting at home with their kids watching this debate, what's he going to do today to give them hope of this situation being resolved? The third thing I want to raise, Mr Deputy Speaker, is the issue of Spinraza treatment for people with spinal muscular atrophy, or SMA. which affects an estimated 1,300 people across the UK. And this can cause irreversible loss of a child's ability to crawl, walk, breathe and swallow. In the most severe cases, it can cause death. Now, Spinraza, as I understand it, is the first possible treatment for those who have SMA types 1, 2 and 3. It can slow down its progression and it can prolong life. This April, this treatment is going to be routinely available in Scotland. It's already available in 24 other countries in Europe, yet it's still stuck in the NICE process for England, Wales and Northern Ireland. And that's why in the end, the purpose of this debate is to ask the government to look carefully at the way that NICE works. New drugs are being developed, technological changes are happening so rapidly that the Minister needs to be able to tell us how the way drugs are assessed and licensed and then approved is going to be working in the future. How is the Minister going to ensure that these groundbreaking drugs are made available to the people who need it and when they need it? In 2016, NICE was not able to recommend the use of Orkambi due to uncertainty around its long-term value, impact and cost effectiveness. But this is available in the USA, across Europe and more recently in Scotland. So when does the government think patients in England are finally going to get this drug? This is really urgent. The system's not worked and patients are being let down. NICE decided on PKU, NICE decided to start an appraisal of Kuvan in 2018, but this has since been suspended. And NICE is currently reconsidering which appraisal process to use to assess Kuvan, and the NHS is considering whether to fund an interim policy for the use of the drug. But again, this is not enough, and it's not quick enough. The NICE process sees PKU as rare, but not rare enough. As we've heard, the majority of PKU treatments are assessed by the STA process, which is designed for non-rare treatments. NICE's approach also values the lifelong cost of treatment, meaning the cost thresholds and the approach to evidence are all designed for more common diseases than PKU. For SMA, sufferers are waiting on discussions between NICE, NHS England and Biogen, who manufacture Spinraza, to come to a deal. So I hope on all of these things, Mr Deputy Speaker, we're going to hear better news from the government than we've had in the past. And in conclusion, I just want to say this. It's my job to listen to people in Dudley who are living with cystic fibrosis, with PKU and SMA and other rare diseases. And it's my job to come down to London and speak up for them in Parliament and to demand, as we're doing this afternoon, that the government ensure they get access to the treatment that they need and they deserve. Thank you.
Emma Lawber.
Thank you very much, Mr Deputy Speaker. I'd also like to thank my honourable friends and my neighbours from the glorious North East for Blaydon and North Tyneside for securing today's debate on this important topic, as well as the Backbench Business Committee for granting it. I want to today focus my comments on phenylketonuria, PKU. This is classed as a rare disorder, but for sufferers the impacts are stark. If left untreated, PKU can result in brain and nerve damage, behavioural difficulties, vomiting, tremors and epilepsy. Yet some of these impacts can be mitigated to a degree if only the NHS would allow the drug Kuvan to be readily available. PKU sufferers cannot metabolise protein and as such are kept on a strict diet and take a large number of supplements to make sure that they do not become deficient in anything that we would normally get from the foods that they are unable to eat. Many sufferers also need to take an unbelievable amount of tablets each day, tablets that are large and difficult to swallow. My constituent Harvey Parker has PKU. He is 15 years old and takes a staggering 65 of these tablets every single day. Mr Deputy Speaker, although a distant memory for some of us in here, I'm sure we can all remember how difficult it is being a teenager. That want to fit in and not stand out. Harvey told me that Kuvan would help him lead a more normal life. Eating out and sharing food with others is an important part of socialising. It's something most of us would do without thinking. But for Harvey, many places don't cater for his needs, and he ends up feeling embarrassed, isolated, angry and a burden. He said when he's been out with his mates on a weekend, he tells his mum and dad he hasn't eaten because he wasn't hungry, but when really it's because he just couldn't find anything that he could eat. Harvey told me that I don't really like to talk to any of my friends about PKU because I get embarrassed. And when I'm with my friends with no tablets to take, blood tests to endure, or bland, unpalatable foods, then I'm just Harvey, one of the lads, and not that boy with the rare, invisible condition that no one has ever heard of. It's really clear to see how access to Kuvan and the more relaxed diet that would follow could improve Harvey's life. It's improved the lives of others who've taken it. So why is it being denied to so many sufferers? It's used by over 2,000 patients worldwide and is commonly used in 23 other European countries, but not England. Some sufferers have had access to the drug on the NHS after costly and lengthy court battles, but most people aren't that lucky. At an estimated annual cost of up to £50,000 a year, the drug remains out of reach for so many sufferers. An adult with PKU's protein-restricted diet costs the NHS £12,000 per year. Many sufferers get prescriptions for their food, which has a high price tag. A packet of pasta is £7.20 and a loaf of bread £7.48. Our NHS was created on the principle that access to good quality healthcare and medication should be accessible to all, free at the point of need, regardless of income. But time and time again, we're seeing under this government destruction of our NHS by stealth with creeping privatisation and a rolling back of this principle. When it comes to Kuvan, constant wrangling has led to the situation where 4 years ago, NHS guidance said there wasn't enough evidence to prescribe it. They then referred the issue to NICE to see if it could be readily available on the NHS. NICE, as we've already heard, has two methods for appraising medicine: the highly specialised technology appraisal for rare diseases and the technology appraisal route for common diseases. They decided to assess Kuvan using the same route as common diseases,
with Emma.
Despite the fact that only 1 in 10,000 people have this illness. Hardly common.
It's not right.
Thanks to campaigning from the National Society for PKU, NICE then suspended this appraisal and decided to reconsider. But the new process has yet to be started.
Exactly.
However, as other members have already noted, the HST route isn't ideal for rare diseases. A whole new, different approach is needed. The NHS also decided to prescribe Kuvan, then changed their mind due to costs. In short, they decided it was too expensive. This is what happens when privatisation and outsourcing are prioritised over patients' care and well-being. Harvey's mum, Diane, said to me, "How can you put a price on my son's health? I sincerely hope the Minister will let Diane and Harvey know."
Shannon.
Mr Deputy Speaker, can I first of all, it's a pleasure to follow the Honourable Lady for South Shields and her passion for the subject matter, but also on behalf of her constituents, and well done to her. And I can also thank the Backbench Committee for enabling this debate to take place, and I was very pleased to go along with the Honourable Lady for Blaydon and the Honourable Lady for North Tyneside, two formidable, diligent ladies who have put their marker down in this subject matter, and I was very pleased as the third one of the trio to be involved with that. But well done to those ladies as well for giving us the opportunity, on behalf of our constituents today, to express our concerns. I am sure that, like me, most in this chamber will have been inundated with emails of people begging to be helped, begging for the drug that they need to be made available. Everyone has said that, and I don't believe that anyone can ignore that either. It's not only about the emails either, it's about the interaction that we have with our constituents, and we hear those stories face to face. And I want to start off with a good story and say what happened, not with this minister, I have to say, but through the Home Office. And I want to refer, if I can, because I fought very hard to see medicinal cannabis legalised for my beautiful young constituent, Sophia Gibson, and what a difference that has made to her life, as it hasn't did to others. Her parents had no other option than to uproot their family, move to Holland to get the treatment that the Sophia needed. At the same time, they were respectively knocking on the doors, following the system, to the Home Office Minister, getting the clinical assistance to bring about the change, and 8 months later, their daughter has been at school more than ever before in all her lifetime, has had substantially less admissions to hospital, and has attended school parties which were impossible and too much for her without this medication. So a very, very different young girl today in a place because her parents, Darren and Danielle, fought the battle in the right way and in the right place. Today, Mr Deputy Speaker, we have all presented our cases for the right battle in the right place at the right time with the right requests. Since that time, I've had so many other parents coming to me and asking me to help secure the drug that their child needs. A mother in my constituency with an absolutely gorgeous young two-year-old son, Lorcan they call him, for whom Orkambi would now help him. Orkambi is a second precision medicine that targets the root cause of the disease and would benefit around half of people with cystic fibrosis in the United Kingdom of Great Britain and Northern Ireland. Cystic fibrosis is a terrible illness that affects the lungs and the digestive system of people with a condition who have a median life expectancy of just 31 years old. Vertex Pharmaceuticals, NICE and NHS England must end, I say this very respectively, Mr Deputy Speaker, I mean it respectively, and I hope it can be taken in, must end the protracted negotiations for the drugs Orkambi and Simkevi, break the stalemate between the three parties and give access to these drugs which so vastly improves quality of life. My constituents and everybody else's constituents here deserve and want that drug and need that drug desperately. I've often spoken on the need to allow people to access Orkambi on prescription. I've often been beyond frustrated with the lack of movement between the drug company and NICE. There must be, and indeed there has to be, something that can be done to find a way forward. And I believe that this is what must be done in this House. And today we look to our Minister and our Government to give us the answers and the answers that we respectively need. We must instruct the Department to negotiate a way forward to ensure that my young constituent and so many others like him can live a better life. I was contacted by Muscular Dystrophy regarding spinal muscular atrophy, SMA. Others have spoken about it on behalf of their constituents. I want to do likewise. It's a rare inherited neuromuscular condition that affects the lower motor neurons in the spinal cord. It leads to the gradual loss of the ability to walk, to crawl, to move, to breathe, to swallow, and is a condition that requires complex medical support. About 100 children are born with this condition each year, and there are around 2,000 children and adults living with SMA in the United Kingdom. Spinraza is the first and only treatment for patients with spinal muscular atrophy. It is meant to increase the body's ability to produce a protein called cervical motor neuron, which is essential for motor neuron health. The treatment is administered through an injection into the spinal canal. It's never an easy treatment, but if it gives that opportunity for better health, then do it. For children with SMA type 1, life expectancy is rarely longer than 2 years. Some children who have received Spinraza have seen their muscle strength improve and have lived long enough to crawl and even walk. For these children, Spinraza has been a lifeline. Spinraza, could I say, has been life itself. Yeah. That's the level we're talking about. Spinraza proved so effective in the clinical trials for children with SMA type 1, the most severe form of condition, that the trial was stopped early so that all children affected by SMA type 1 could potentially access a treatment. The Spinraza appraisal has taken almost 14 months, and at the present time 25 European countries, including Scotland and the United Kingdom of Great Britain and Northern Ireland, have already made Spinraza available nearly 2 years after the European Medicines Agency granted Spinraza the licence. Translarna, whilst it is eventually approved by NICE in July 2016, took over 2 years from the European Medicines Agency giving a licence. So these lengthy delays to a process which could and should be significantly shorter has resulted in frustration and anxiety for many families who see a life-changing treatment within touching distance. They almost can reach out for it, but they can never get it, and that's where the frustration creeps in. This is another group of people who see a better life, but are prevented from accessing it. There has to be a better way, I believe, Mr Deputy Speaker, Minister, of dealing with these things. We must find it, or instruct the Department to find it. My heart aches as a father and as a grandfather who would do anything for his children and grandchildren, as other honourable and right honourable members in this chamber would do the same for their children as well. I understand that this block to life-changing drugs doesn't simply affect the child but the entire family. And we must remember, the child or the adult, maybe the person who's disabled and has a physical disability and has a problem and disease, but the family feel it all as well. The family live with it every day. So for so many entire families in the UK who do not have the access to life-changing medication, I wholeheartedly and sincerely urge the Minister in this department to enter into talks, find a way forward and do better so that they can live better. Mr Deputy Speaker, the Government has set aside £40 billion for extra health. I welcome that and I put it on record, as we all do in this House. Can I suggest very gently, set some of that money aside for life-saving drugs?
Mr Deputy Speaker, and it's a pleasure to follow the Honourable Member for Strangford, and I congratulate the Honourable Member for Blaydon and North Tyneside for securing, and the Backbench Business Committee for allowing this debate today. This is not the first time, Mr Deputy Speaker, I have spoken in a debate like this, and I should declare an interest. My 2-year-old granddaughter, Saoirse Fellows, has cystic fibrosis. We are very fortunate she's pancreatic sufficient, but it is still a real worry for our family. I should also mention, I think, that I'm waiting for granddaughter number 4 as we speak. So, right. So if I'm a bit light-headed, this is why. I've never listened to a debate either in Westminster Hall or in the Chamber where so many people have put up Scotland as a great example of how to do things. This is normally just my job in debates like this, so I am grateful to members who have already done part of this job for me. There are an estimated 7,000 rare diseases that affect about 3.5 million people in the UK, and around 80% of these diseases are genetic. It's reported that 95% of rare diseases have no approved treatments available. The default NICE referral route for the majority of orphan medicines is for the STA route, the single technology appraisal, but many will be close to meeting the selection criteria for the highly specialised technology programme, and this has already been mentioned, and stakeholders have frequently sought to make the case for an HST referral, which is a more appropriate route for orphan medicines. The Government has maintained the position that it is appropriate for orphan medicines to be considered under NICE's standard STA, and the orphan medicines have been successfully reviewed under the STA programme. And many members today have already spoken about how this isn't working for their constituents. The Scottish Medicines Consortium, the SMC, has adapted their processes to increase the input of clinicians and patient group experts in decisions for certain orphan medicines. Mr Deputy Speaker, I'm cutting this speech because I want to allow more time for both the opposition and the government ministers, but Scotland and the SMC has led from the front, and NICE has adopted many of its methods in the past, and I would encourage the Minister to look again at what Scotland is doing. We're a small country, we're a devolved nation, but we can do it. So I can see no reason why England NHS shouldn't be doing and getting the same thing as we do. We have a higher approval rate, and in Scotland 69% to 55% in England. We have a new medicines fund specifically for orphan drugs, which is instrumental in helping secure access to medicines for rare diseases. That doesn't exist in the other devolved nations. And both Scotland and Wales have taken a more proactive approach to address concerns to the applicability of standard processes for orphan treatments. The new medicines fund has really helped deliver better medicines more quickly to Scotland, and the fund has covered the cost of orphan drugs for individual patients where the condition affects fewer than 1 in 2,000 people. A total of £21 million was made available for the fund by the SNP Scottish Government, and the Government in Scotland has since made further improvements, reforming access to new medicines by creating the peer-approved clinical system, PACS, Tier 2. Now, this system allows clinicians on behalf of their patients to ask a PACS panel whether they can access a medicine that has not yet been recommended by the Scottish Medicines Consortium. And that is exactly why Orkambi and Simkevi are able to be used in Scotland. And it's absolutely imperative that this is looked at in England, I would suggest. Also, Spinraza, as already been mentioned, is already being used in Scotland, and this means that can I ask the Minister why this isn't possible for NHS England and for these drugs to be used in England to the same extent as they are in my own country? I don't want to bring too sour a note to the end of this debate, because there is real consensus across the House in terms of members speaking sincerely and passionately on behalf of their constituents and others across the country. But I worry, and I think many other members across this chamber will be worried, as we are heading towards a Brexit that no one knows where it is going, the impact that this will have on the availability of medicines generally, and more importantly for this debate, on medicines that are not yet even available in England as they are in Scotland.
Mr. Sharon Hudson.
Thank you very much, Mr Deputy Speaker. And it really is a pleasure to be here this afternoon taking part in this very important debate. And I'd like to start by thanking my friends, the Honourable Member for Blaydon and the Member for North Tyneside. We are part of the North East Massive, so I am very pleased to be joining them in this debate today. And also thank them for their very passionate and heartfelt contributions. I should also mention, as part of that North East Massive, it goes without saying, my honourable friend, the Member for South Shields. I'd also like to thank all other honourable members who've spoken for their excellent contributions, but they know who they are, I don't need to name them, and they were all fantastic. Throughout this debate, we have heard of the heartbreak of patients and their families and what they've experienced because they are unable to access life-saving drugs on the NHS. We have heard of their determination to continue fighting to get access to those drugs, be it writing to their MPs or even protesting on Parliament Square. And I was happy to join my honourable friend, the Member for Bristol East, at the Cystic Fibrosis Trust at their rally just 2 weeks ago on Parliament Square, where they were calling for Orkambi now, and they were very loud. You could even hear them over the chants of no Brexit, or whatever the current shout was at the time. We must hear patients' voices in this debate, as it is them and their families that are affected the most by the appraisal processes that just frankly aren't fit for purpose. I hope the Minister has heard, and I'm sure he has, the real-life experiences of patients throughout this debate and continues to listen to them after the debate too. I know he is also in regular communication with patients, and in my role as the Shadow Public Health Minister, I've regularly met with patient groups and campaigners, and I know just how important access to these life-saving drugs is to them. As a constituency MP, I also recently met young Riley and his mum Michelle. Riley has PKU and he needs Kuvan. He's now 11 and he's at secondary school, and he just wants to blend in with his mates and be able to go on those first excursions out to the Metro Centre and maybe even get something, you know, unhealthy from a takeaway, something like that. But obviously he can't do any of that. And I asked him about his life and how he felt not having access to Kuvan, and he said it wasn't fair and it made him mad. Well, I agree with Riley. I've heard it can take years to get the right diagnosis of a rare disease, and that once patients have that diagnosis, they feel there's been a breakthrough and they're excited and think, finally, we'll get the treatment now that we need and deserve. But instead, as we know and we've heard today, they are back to the beginning of the fight, as the life-saving drugs that do exist just then aren't available to them on the NHS. So it's one hurdle after another for patients with rare diseases. And that is why on this side of the House we strongly believe that patients should have fast access to the most effective new drugs and treatment. I'm therefore pleased to support the motion that's been put forward today. And as we've heard, a rare disease is generally considered as one affecting fewer than 5 in 10,000 people. According to the 2013 UK Strategy for Rare Diseases, it is estimated in the UK that more than 3 million people will suffer from a rare disease at some point in their life. All of these patients must have access to the drugs and treatment that they need. However, they are being failed by the NICE appraisal process. That it's just not fit for purpose to assess the suitability of drugs and treatments specifically for rare diseases. Patients with a rare disease are squeezed in the middle of 2 appraisal routes, as we've heard, the highly specialised technology HST evaluation programme and the single technology appraisal STA route. The HST evaluation programme is selected for most non-cancer rare disease medicines and is designed for evaluating medicines of this nature with small patient populations. However, the HST programme currently lacks the capacity or capability to effectively appraise all new licensed orphan medicines. Since the HST programme was established in 2013, it has published guidance on 8 medicines, much fewer than the 45 orphan medicines for non-cancer indications which have been licensed in the same period. The STA route is designed to appraise treatments for more common conditions and those with existing treatments. This route is poorly suited to considering rare disease medicines, which tend to have small patient populations, a limited evidence base and benefit beyond direct health benefits, something the appraisal process just doesn't take into account. Some rare diseases aren't rare enough for the STA route, and only a handful of medicines are being approved by the HST route. So yes, it's complicated, but it's therefore clear that neither route is working for patients with rare diseases. This means that patients are missing out on crucial medicines. Kuvan was licensed in 2008 to treat PKU patients, but it's still not available to patients in England. Orkambi was appraised by NICE in 2016 through STA, but was recommended for use. 3 years later, as we've heard, people with cystic fibrosis still do not have access to Orkambi. This has caused physical and psychological harm to patients and their family. Every day without the drugs they need makes their condition worse. We therefore need an appraisal process that will capture rare diseases effectively. Medicines to treat rare diseases are often found to be cost ineffective, and that is why they are then not approved for routine commissioning. However, establishing value for money is not straightforward, especially when population groups are so small. It does not either sit comfortably with me, or I'm sure any of us, that cost effectiveness is prioritised over clinical need or the lives of children, as we've heard. I know that manufacturers want to make a reasonable return, although some of these figures are huge, on their investment. However, I do not think that this should be a priority, and manufacturers must not hold NICE or NHS England to ransom for their own financial gain. Or the government, exactly. Behind profit forecasts, there are thousands of people and families who need access to life-saving drugs, and they simply cannot wait any longer. We must not put businesses before patients. Because of the NICE appraisal process, patients and their families are left in this awful limbo. The process can be so long-winded, confusing and difficult to navigate. Some medicines can undergo multiple assessments while others are not assessed at all. And this creates an unpredictable and unattractive system. As a result, patients are left in the dark as to when and if they will have access to innovative treatments for their condition. And when a drug is being appraised, patients live in the hope that this will be the time that it's going to be approved for use on NICE, like in the case of Mariam, as my honourable friend for West Ham so powerfully described. But they are almost always left to feel disappointed and helpless. Patients and their families must be involved in the processes, and the processes must be transparent.
Waiting for access to drugs is an excruciating wait, especially when the drug is available in nearby countries or even in Scotland, as we've heard, with Spinraza, which it's available to patients up there, but not patients in England. And this is something my honourable friend for West Ham spoke so passionately about on behalf of her constituents and their 7-month-old baby, Mariam, who was frankly, it sounds blunt, but she's dying because she has been denied access to medication that could extend and enhance her life. The pain and anguish parents of a critically ill child must feel when they are told that there is medicine available that will help, but it's not available to their child. I mean, that just must be unimaginable. And to know that if your child lived just a few hundred miles away in Scotland or perhaps somewhere in Europe, that the drug would be available is heartbreaking and infuriating. Parents and patients in England should not be left behind in this. We need to be working to find ways to get these medicines to the patients that need them on the NHS, and I hope the Minister will consider this motion seriously today for the patients with rare diseases and their families. They cannot be left behind any longer, and they must get access to these life-saving drugs now. Thank you.
Sir Steve Brine.
Thanks very much, Mr Deputy Speaker. Let me add my congratulations to the Honourable Lady from Blaydon on securing the debate. I'm not familiar with the North East Massif, but I am now. Very good, very good. I'm familiar with the North East Massif in their individual component parts, especially my shadow from Washington and Sunderland, but I've not seen them as a collective before. But I must say, Mr Deputy Speaker, they hunt well as a pack. Excellent. So congratulations to the lady from Blaydon on securing the debate. And I recognise her work and chairing the all-party group on PKU. We have discussed these matters before in Westminster Hall, and I do not doubt we will discuss them again. We've also heard from other members present today who've spoken very passionately on behalf of their constituents about how important it is to access new medicines, and members, as the gentleman from Dudley North rightly said, are doing their job. I'm doing mine. And I have, as requested, listened very carefully to the debate this afternoon. So thank you to the honourable friend from Reigate, the lady from Wolverhampton South West, Bristol East, West Ham, Liverpool West Derby, Hayward Middleton, Dudley North, as mentioned, South Shields, part of Massif, hashtag Strangford, and the lady from Motherwell and Wishaw who speaks for the SNP. The gentleman from Liverpool West Derby touched on cannabis. I mean, I happily write to him about that in more detail if he wants. I mean, as he knows, he made the issue. The government, the APPG report came out yesterday, which I haven't had a chance to look at yet. I'm aware of it, obviously. I mean, the government changed the law, and specialist doctors can now provide cannabis-based medical products where there is clinical benefit. But so to support doctors in this, because the politicians are ahead of the clinicians on this one, we asked NICE to develop new clinical guidelines. We asked Health Education England to provide additional training while encouraging more national research to develop the evidence base in this. But I think I've said before, I shall say again, I'm very clear that I think we need to provide more support and encouragement to commissioners in this space, because, as I say, I do think the politicians are ahead of the clinicians on this one. So, everyone's spoken incredibly passionately, and there's been very little politics in it, which has been excellent at the end of this week, and it is very good to hear Parliament discussing something else, which of course it does all the time. It's just that that's never reported. I dare say this won't be either. But the government shares the view of everyone in the House that it's in the interests of all NHS patients. We've got the best system in place for making evidence-based decisions on whether new medicines are routinely available. Of course, it's easier when you are on the backbenches to just say that the system is hopeless. But we have to work with the system that we have or change it. And we inherited the NICE set up by, it was in the first Labour Queen's speech in 1997, created in 1999 in a delegated legislation committee by then Health Minister of State John Denham. He's a good man. And he set it up, and as he did when he did at the time, he said it was set up to make independent evidence-based recommendations for the NHS on whether drugs represent an effective use of NHS resources. Now, NICE is widely recognised as a world leader in the field of health technology assessments. Its methods, its processes, they've been developed and continuously refined over the last 20 years, so it's 20 years this year, through periodic review and engagement with stakeholders. Politicians are not in the middle of those decisions. Rightly so. That's how the system was set up by the aforementioned Mr. Denham. Maybe the lady from Hayward and Middleton was right to have trusted her instincts. No, I won't actually, because she's had her say, and I'm going to have mine in the short time I've got. And if I've got some time, I think, Mr. Deputy Speaker, I think the honourable lady has spoken on behalf of her constituent a lot today, and very well. And I don't think, given the tone of this debate, we need to get unpleasant in here. And I think that I will address the points in my speech. And if the honourable lady doesn't like that, then I'm sorry. But I don't think that anybody watching this, least of all the families affected, need to hear that tone. Now, as a result, Mr. Deputy Speaker, Mr. Deputy Speaker, I will let you...
If the Minister wishes to give way, it's up to the Minister, and we've got to let him finish his speech. Minister Steve.
Indeed, Mr. Deputy Speaker. Some people just cannot help themselves. So, firstly, NICE operates two separate programmes for the assessment of new medicines. There is a technology appraisal programme through which NICE assesses the vast majority of new medicines. Secondly, as said, there is a highly specialised technology, or the HST programme, that is reserved for the evaluation of very high-cost drugs for the treatment of a very small number of patients in England, treated in a handful of centres in the NHS. Now, decisions on whether a medicine should be routed to NICE's mainstream technology appraisal or the HST programme are taken through an established topic selection process that includes consideration against published criteria and engagement with a wide range of stakeholders. So when NICE recommends a drug for use through either route, NHS organisations are legally required to provide funding so that it's made available to patients. Now, today we have heard concerns that NICE's technology appraisal programme is not suited to the assessment of medicines for rare diseases, with some calls for individual drugs to be assessed through the HST programme instead. We've also heard calls for a third appraisal route for rare diseases not eligible for the HST programme, and I have listened very carefully to all of them, and I will reflect on them all, and there is some sense in a lot of what has been said. Indeed, over the last 20 years, NICE has made positive recommendations in 75% of its appraisals, that is the figure, of orphan medicines. By comparison, NICE recommends around 80% of medicines for more common diseases. To just give two recent examples, because we only ever hear of the examples, of course, that are stuck or refused, NICE has been able to recommend orphan medicines for neuroblastoma, which is a cancer of the nerve cells that affects children, which has been very widely welcomed, primary biliary cirrhosis, which is a progressive liver disease drug. Moreover, through the HST programme, NICE has to date been able to recommend a further 8 medicines for NHS patients outside of the standard appraisal rate. So in each case, their recommendation is subject to the managed access agreement negotiated between the drug company and NHS England. Now, there will always be cases, Mr. Deputy Speaker, where NICE is unable to recommend a medicine because the price set by the company doesn't reflect the benefits that it brings. That is a fact. Honourable members have spoken, of course, about the rare diseases of people in their constituencies doing their job. But NICE is an independent body, and it should be allowed to develop its guidance free from politicians, as the lady from Hayward and Middleton said was her initial instinct before she became a politician. And that is the foundation of NICE's reputation as a world leader in its field, and it's in the best interests that it does that. Now, the lady for Blaydon introducing the debate raised concerns about Kuvan, the treatment for PKU. Now, NICE has initiated an appraisal of Kuvan, and officials from NICE, NHS England and our department have been reconsidering the appropriate assessed route in the light of the new available information which she spoke about. And Riley is right. We've got to make this fair. And a final decision will be taken promptly, I am told, and I will urge that again from the dispatch box today, with minimum impact on the timetable for NICE's assessment. The member for Strangford, the member for Bristol East, the gentleman from Dudley North, who has spoken up on the issue of Orkambi so many times and so well. It is incredibly frustrating and incredibly disappointing to ministers as much as it is to him and to everybody else that Orkambi is not available to NHS patients in England at the moment. Mr Deputy Speaker, I understand and share that frustration. That's why the Right Honourable Friend of the Secretary of State held a meeting with Vertex and NHS England and NICE a couple of weeks ago. I was at that meeting and the parties discussed again how best to reach a conclusion. I'm very pleased that they are meeting today. In fact, as we speak, they are meeting to continue discussions and decide on the next steps. And decisions about availability of drugs in Scotland are, of course, they're a devolved matter, and this is up to Scotland. I understand no decision has been taken on routine funding for NHS patients in Scotland, but the lady from Motherwell and Wishaw asked me to look again at the Scottish system, and I will do that, and I will ask the Minister responsible for this policy area to do so. The lady from North Tyneside raised the issue, as did others, about Spinraza for the treatment of SMA. I understand that NICE's Independent Appraisal Committee met earlier this month to consider its recommendation on Spinraza following new evidence put forward by the company. NICE wrote to the company and patient groups last week to say it wasn't able yet to provide an update on the outcome of the meeting, but it will provide an update very soon. And again, I will encourage that to happen even sooner. I recognise that the productive process in this instance is hugely frustrating and upsetting for patients and their families. And, you know, whatever our differences across the dispatch box, of course I feel the deep hurt that the Honourable ladies who spoke on this subject laid out. But I hope they'll appreciate that no final decision has yet been made, and NICE has got to be allowed to complete its work free from political interference. Now, I don't have any time to go into a huge amount more detail, Mr Deputy Speaker. You know, I've been asked lots of questions during this debate. I have very little more time than people who spoke in the debate, but I thank people for speaking so passionately. I hope that members will welcome the forthcoming review of NICE's methods and processes, which is what's called for, or at least partly, in today's motion over this year for both its technology appraisal and its highly specialised technologies programme. It wouldn't be appropriate for me to preempt that review by commenting in detail on what it should look at, but I will ensure they are directed to the motion before us today and to the transcript of today's deliberations. And I wanted to give time to the Honourable Lady who introduced the debate to close it in the time that we have. Thank you.
Liz Twist.
Thank you, Mr Deputy Speaker, and I hope the honourable members will forgive me if I don't list them all, but I want to respond to the Minister. First of all, Minister, it's not easy for us from the back benches to criticise and lobby. It's really difficult because these are our constituents. They are real people who have conditions. And what we've tried to do in this debate, Mr Deputy Speaker, is be constructive and say, actually, we have identified some issues around the NICE appraisal system which we think need to be addressed urgently. I noticed as the Minister closed he talked about a review and drawing this to their attention, but can I ask the Minister to ensure that there is dialogue and input before that review takes place to see that it's not simply technical, it actually addresses the concerns that we've raised. And I see the Minister nodding, so perhaps Hansard can record that. So he's said as well that he's heard from us before about these issues, and I can tell the Minister that he's going to hear from us again.
Sorry about this, but we have run out of time. Order, the debate now stands adjourned.